Hi guys, it's X. Welcome back to my channel. On today's video, I'm going to be discussing how I would like you to trust your gut as a nurse when advocating for your patients. So what I mean by that is there have been numerous times where I have brought up concerns to a doctor who sometimes don't immediately agree with what I'm seeing, my assessment, or what diagnosis I feel is going on. And in that process, I stuck to my guns, I stuck to my heart, I stuck to my intuition, and I ended up advocating for this patient and ended up being correct overall. So I want you, this is what this video is about. Some of my examples are from years ago, so I'm hoping all the nitty-gritty details are still in my head to explain further to you what happened in these situations, how I trusted my gut, and what the patient's outcome was. So if you guys want to know my thoughts and opinions on this subject, just keep on watching. But before you swipe me away or click me on this video, please like, comment, and don't forget to hit the subscribe button. Thank you. As a nurse, obviously, we are not meant to diagnose, but we are at the bedside 12.5 hours a day. And the doctors see the patients probably between rounding, looking all over their chart, and coming to actually see the patients 1 hour. I mean, come on, they have several patients to see, and depending on what unit you're on, you probably hopefully have max of 5 people. So that gives me more time at the bedside. And if you don't know, I am an ICU nurse, but I recently did become a nurse practitioner. And one thing that made me feel so smart to want to actually further my career and become a nurse practitioner was that I always had this intuitive, gut feeling about things, and they ended up being right. And I was like, oh, maybe I could be a good nurse practitioner someday. This kind of gave me the inkling and the push to want to further my career. But one day, while I was in NP school, I realized the reason why I always get these gut feelings and I always get these diagnosis correct is because I'm actually at the bedside all day and I'm watching these trends and I'm watching these things. So I am here to encourage you that if you feel something is wrong, and even though the doctor might not agree with you right away, if you truly feel like something is going on and nobody's listening to you, trust your gut and find the evidence and present it. And I'm gonna give you 3 to 4 examples of what has happened to me in the past to make me push for these test diagnostics and then what the outcome was. So the first story I have was years ago, and I remember I got this patient on a Friday. They were a long-term traumatic brain injury patient who came in with sepsis from a pressure sore. And this person had been in a persistent vegetative state for years. So I learned some things based off this case and everything watching. So I'm taking care of this patient. Third day that I have this patient, I start to notice that my urine output is starting to increase. And I'm talking about going from a normal maybe 50 to 100 cc's an hour to now 200 cc's an hour. Then it starts slowly increasing, and then I realize I'm dumping 400 cc's every half hour. And I'm like, DI. That is what I'm thinking, but I'm thinking about it because diabetes insipidus can happen with traumatic brain injuries, but this patient wasn't here for a new traumatic brain injury. They were here for sepsis. Now, at this point in time, I actually didn't know that sepsis can trigger this event in this specific type of patient years down the line. So I go to my intensivist and I'm like, doctor, I really think this patient is in DI. And my doctor is like, no, the patient got a lot of liters of fluid in the ER. I think the patient's just autodiuresing. And I was like, no, I've had this patient for 3 days. This is the 3rd day. Would that happen this time around? And, the doctor had already seen the patient, had already rounded. And he was like, no, I really don't think that it's DI. And I was like, okay. So I look at my resources, and I'm like, no, something is wrong. My urine is clear, almost like water. I was like, I'm dumping at this point 400 cc's every half hour. Like, the amount of fluid that I'm currently infusing is not adding up to amount that's coming out. So I look to my pharmacist, I'm looking at all the medications that my patient is on, and I look at my pharmacist and I'm like, hey, will you advocate with me? Like, will you go over the meds and see that nothing is triggering this? Like, they're not getting Lasix or anything like that. Like, I don't understand what would trigger this. And she's like, okay, well, let's look at the types of GI. There's nephrogenic GI and, you know, from the brain. So I'm like, you know, I really just want him to come look at it. So he happened to be walking by and I said, hey, can you please just look? And he looks at my folate and he starts laughing. And he's like, oh my God, it is literally pouring out like a faucet. Okay. So we look at the pharmacist and he goes, okay, give a shot of DDAVP subcutaneously and see what happens. Almost immediately, urine output stopped. Patient happened to be in DI. That was triggered by the sepsis. And I did not know that this can happen years later. I always thought like, okay, fresh traumatic brain injury, diabetes insipidus could be something that happens, but this happened years ago. So it was a really good learning point, but I'm really glad I stuck to my guns because it ended up being the diagnosis that was at hand. The next story I have for you, I had this patient that was on a ventilator. They came in with COVID and we really didn't have any past medical history on this patient. They came in ARDS, unfortunately, so they got intubated immediately and family didn't really know much about the patient's past medical history. So one day I'm taking care of this patient and I see as I'm doing catheter care that there is pus coming around from the catheter insertion site, not to get too graphic. So I talked to the doctor and he goes, go ahead and send out the pus for culture. So I do. Obviously that takes a while to grow. So later on in the course of me taking care of this patient, I start seeing, because this patient was there for a while, I start seeing charting that there's like excoriation in the genitalia. And I don't get the same patient every single time I go to work, so it's been like a while now. And I look and I'm like, this does not look like excoriation. It kind of looks like healed vesicles, but I was like, I kind of have a feeling that this is herpes simplex 2. And I'm like, but I've never seen herpes in person. I've also never seen herpes healing. I've only seen herpes in photos and I've only seen them as vesicles. I don't know what the healing process looks like because I've never seen it before. So I call our infectious disease doctor and I tell him like, hey, I'm really concerned that this patient might have herpes. Can you please look at the genitalia the next time you see the patient? And he's like, oh, go ahead and start him on the acyclovir and get a urology consult. And I'm like, what if I'm wrong though? Like, I don't want to start somebody on acyclovir if it is not, you know, in fact herpes. And he's like, okay, wait for the urologist to come see this patient and then, you know, we'll proceed from there. Okay. So urology comes, we're in the room looking at it. No, that's not herpes. Like, I don't know if I remember if he said it was like contact dermatitis or like just not being properly cleaned and just shearing like on the sheets and stuff. So he's like, just put some like Neosporin on it and we're good to go, not herpes. And I'm like, okay. So I leave, you know, I'm cleaning up, whatever, take off my gown, I leave, I go sit down on my computer to chart, and what pops up? A culture for herpes. And I'm like, wait a minute, like, you just told me it wasn't herpes to just put Neosporin on it. Now you want me to culture it? Like, wait, I don't know what's going on here. Like, okay. So I go, I culture it, send it out, don't see this patient again. I'm not taking care of this patient. Now, remember, herpes is an infection that can be triggered by other infections. This patient happened to have COVID. We wouldn't know if they had herpes in the past or because the family didn't know. And who's going to share that with their family? Like, I'm not going to tell my parents if I have something or my kids. Like, it's embarrassing. So I'm sitting at my desk a couple weeks later, or a week later, and I hear infectious control comes around and he asks me, hey, are you taking care of so-and-so? And I was like, no, I don't have that patient today. So then he finds the nurse. She happens to be sitting across from me. And he goes, so it turns out this patient has herpes. I jump up so quickly and I'm like, I freaking knew it. Like, I knew it. I knew he had herpes. Like, I knew this was an outbreak. I thought I was crazy. Everyone thought I was crazy. You know, urology came by, did a preliminary, assessment. I said, but to be safe, like, we took the culture anyway. And glad I trusted my gut. Glad I brought it up to the doctors. And I'm glad somebody addressed it. And come to find out that the patient ended up having fungemia. And the culture that I ended up taking originally from the catheter insertion site was fungus. So it had spread, unfortunately, to the blood. So that is just another example of why you should trust your gut, why you should advocate for the patient, and why you should always alert the doctors. Another and my last example is I had this patient for 5 days. And I noticed on the 5th day at 4 p.m. that the patient looked jaundiced. And I thought I was tripping. I thought I was crazy because I was like, does this person look jaundiced all of a sudden? And I've been a nurse for 6 years, but one thing I will not do is not ask for help. I always want a second opinion. I don't care how much experience I have or what I know and don't know. If I feel like something's off, I'm gonna go and ask other people for their professional opinion, because just because I have or don't have experience in something doesn't mean somebody else will or won't. So I always ask for a second opinion if there's something that I feel just isn't wrong or doesn't feel right internally. So I'm like, there's no reason why this person should be jaundiced. But a couple days prior, I had been looking at the labs and I'd been looking at the trend, and I brought it up to the doctor because on admission, this patient's LFTs were elevated. I want to say the AST, ALT were like 120 and 80. Then they came down to like 70 and 50, and then they normalized. But then I noticed it spiked along the way, and then we didn't check them. And so I had told my doctor, I usually work Friday, Saturday, Sunday. I usually tell my doctor, like, hey, I noticed on this day, like, the LFTs were elevating, but they had normalized. Like, what could possibly be causing that? And he's like, I don't know. We'll keep an eye on it. Whatever, we brushed it off. But now on the last day that I'm taking care of this patient, and I'm gonna be off the next couple of days, I'm like, they look yellow all of a sudden. Why? So I bring up the labs and I'm looking and I'm like, there's no CMP, there's only a BNP. So I don't have LFTs. The last LFTs were run a few days ago. Oh, I'm lying. There were LFTs done the day before. They were normal because my bilirubin, I had a bilirubin that was normal. It was like 0.6 or something. And so I go and I ask a coworker, can you come look at my patient? I think they're jaundiced. So I'm looking at the sclera. The sclera is yellow, a little bit tinged, but I see that the jaundice is not spread throughout. There's two things that cause jaundice: obstruction or hemolysis. So I'm like, this patient got blood, but on admission. We're out from admission now. So I'm like, I don't think it can happen this close into, the disease process of what this person's here for. And sorry, I can't give too much detail. So I'm like, it's not that, but this patient did complain of abdominal pain, the reason why they came to the ER, but there was like nothing that was found. Something else ended up triggering this person to come in. So I was like, CT scan, negative on admission. Ultrasound, negative on admission. So I'm like, there was some sludge in the gallbladder, but nothing crazy out of the ordinary. So I go to my pharmacist, look up all the medication, nothing. I am not giving this patient absolutely anything that's causing liver failure. The only thing that was there was acetaminophen. Was not giving acetaminophen over 4 grams a day or over 2 grams for the elderly, nothing like that. So I'm sitting there thinking, and I'm like, I go and I get my CNA. Why do I get my CNA? Because my CNA helped me turn this patient every 2 hours for the last few days. So she has seen my patient as much as I have. And I'm like, do you feel this patient is jaundice? Like all of a sudden. And she's looking and she's like, kinda. We turn the patient to the side. Clearly, the back does not match the legs. Yellow. So yellow. And I'm like, I'm not crazy. I know it. So I go to a friend of mine that is a doctor who's best friends with my intensivist. And I'm like, hi, how do I convince your friend to let me order a CMP? I said, my patient looks jaundice. And he's like, well, like, is there any meds indicating? I'm like, no, I checked. And he's like, well, your labs were normal yesterday. And I was like, I know, but no, I'm telling you something's wrong. And he's like, you can't have a normal bilirubin and the patient be jaundice. And I said, I know, but that was yesterday at like 4 o'clock in the morning. It's 4 p.m. now. Something is wrong. Something is up. And he's like, I'll go walk by and look at the patient. So we walk by and he's like, a little jaundice, but wouldn't worry about it. And I'm like, okay. So I'm adamant because I'm like, I can't let this go. Something is wrong. And so I'm like, this is my 5th day in a row with this person. I know what I'm talking about. They're jaundice. So I go to the doctor, my intensivist, and I'm like, please run a CMP tomorrow. Please. I said, something is wrong. And he's like, okay, if it'll make you feel better. I was like, I don't know why, but in my gut, something's wrong. All right. Next day, bilirubin, 5. Went from 0.6 to 5. When I say trust your gut, trust your gut. Advocate for your patients. Do what you can. But make sure you have all the evidence. In this situation, I didn't have any. I looked at the labs, looked at the trend, saw that something funky was going on with the trend, but the day before did not match my presentation. And I was like, I don't have evidence. I don't, besides my gut and besides, like, I've been here 5 days, 12 hours a day, seeing this, like, change all of a sudden, there's something wrong. So I was really thankful that I stuck to my guns. I was really thankful that my doctor was willing and open to listen to me and hear me out. And I unfortunately don't know what happened to the rest of the story, but I was really, really glad that I stuck to it. So what I don't want you to do is advocate and push without having all the evidence, without having looked things up or seeing trends or knowing what you're talking about. And I'm going to give you one scenario. I, in my career, have unfortunately come across some nurses who are just very cocky, very condescending, do not have like a nurturing relationship in the hospital, unfortunately. And unfortunately, in your career, you're going to come across that. I have worked with nurses who float from other units who make it known that they don't want to be there. And because of that, I've learned early on, if I get floated to a unit that I particularly do not want to work on that day, hi Kabuki, I just suck it up. I smile, put on a happy face, and do my job. Because I remember how uncomfortable it was when a nurse from a higher acuity would come to a lower acuity and they'd like slam their papers on the floor and like huff and puff and like just make it known and uncomfortable that they didn't want to be there. So I float to this unit once, I'm an ICU nurse, and I never tell anybody my credentials unless they ask. I don't tell anybody that I'm a nurse practitioner working as a nurse still. Like, I don't say anything because there's just no need to. So unless you want to know, like, oh, where do you come from? You know, I haven't seen you before, because that happens. I mean, hospitals are huge. You're not going to know all your coworkers. And so I don't say anything like what unit I'm from or what my experience is unless somebody asks me. So I float to this unit one day, and I unfortunately have a nurse who I feel was being very condescending towards me. But she was wrong in every single aspect of things that she was bringing up. And I'm like, this is exactly why I'm never cocky. I don't throw my education in anyone's face, because there's just no need to make somebody feel insecure, less than you, or dumb. Like, there's just no need. If I see that something's wrong, I will teach you, I will train you, I will explain why this is wrong and why we should do things differently. But I would never be condescending to somebody and be like, you're an idiot. That just, it's uncalled for. So anyway, to move along, patients in this unit that is like an OBS unit. I've never been to this unit before, but I'm passing off information to the night nurse. And the night nurse comes in, and I didn't know, I gave a report on 2 different patients. This doctor had just made changes, made the patient NPO at midnight, and put fluids on. I did not know if the person was going to surgery. Nobody called me and told me anything. This order was just put in. Doctor did not consult me on anything. So I didn't know why patient was NPO at midnight and why they put these fluids if there was like surgery the next day. So I can see how the nurse probably had a preconceived notion that I probably didn't know what I was doing, right? So move on to the next patient. The next patient we were talking about, and I had told the nurse, look, I paged the doctor 3 times. Patient complains of pain medicine. Patient says that his Achilles tendon is hurting him badly, like that it's like cramped. I tried asking, like, is it like a Charlie horse? Like, is this new? Did you injure yourself? Like, what is going on? Because patient was not here at all for that situation. Completely different. Patient had an infection. I paged the doctor 3 times, not just because of the pain medicine, but because I had read the notes that stated this patient's antibiotics should have been escalated, and it wasn't. So I was trying to advocate for the patient, because I was like, in your notes yesterday and today it says to increase and escalate antibiotics, yet nobody has done so. They're still on the same antibiotics from admission. So I was calling about pain medicine for the leg, and I was also calling about the antibiotics. So I was like, unfortunately, the doctor hasn't gotten back to me. Patient is complaining of some Achilles tendon pain. It's one side. Asked him if it was, an injury or what happened. And she goes, well, this is your problem. There we go. She points at Lipitor. And I'm like, no. I said, I'm sorry. Like, I get where you're coming from. Lipitor can cause muscle aches and pains. However, patients have been on Lipitor for a while. This is a chronic Lipitor patient. I really don't think that it's going to cause one single muscle cramping. Like, it would probably be a general malaise. So I get where you're coming from, but no, I really don't think that that is the cause. But you know what? Good assessment. Like, I agree that could be a good assessment, but I really don't think that that's what it is. She's like, well, there you go. Your magnesium's high. Okay. I was like, no, once again, I was like, at this point, I'm not trying to say like, no, that's not the reason because of this. That's not the reason because of this. Like, I wasn't trying to actively educate you on why you're wrong. Like, that's not my job. I don't want to come off rude, and I'm not trying to be condescending back, but the reason why I don't think this Achilles tendon pain is from magnesium is because it's actually something that you give to relax muscles. Magnesium is a natural muscle relaxer. That's why we give it to women who are preeclamptic. That's why we give it in like anti-shivering protocols for targeted temperature management. Like, we want the magnesium to be high to decrease the deep tendon reflexes. So no, I don't think that a high magnesium, and it was not very, very high. I was like, in my head, I'm like, not the reason. And then she's like, here you go. look at your calcium, it's low. And I'm like, okay, well, I looked at my albumin. My albumin was low. If you don't know this, your calcium will give you a false low unless it's an ionized calcium if your albumin is low. So I knew that, but I was like, you know what? I'm done here. Clearly this nurse doesn't think I know what I'm talking about, doesn't think that I know what I'm doing, and she is just trying to pinpoint every single thing that could be wrong with patient, but she's wrong in every single sense. Like, I get where you're trying to go, but your evidence is just not there to back it up. So, moral of the story, advocate for your patient. Do what you need to do to get stuff done. Open your mouth and say something. Do not be afraid to speak to your doctors. Hopefully you work in an environment where doctors are very open, trust their nurses, and are willing to hear you out. I love working in an environment like that. I know what it's like to work with a doctor who doesn't want to listen to you, doesn't agree with you, and just doesn't even give you the time of day. When I have a doctor who's like, what's going on? What do you feel? What do you need? Like, do you need any orders? Like, I love having that nurse-doctor relationship. And it really sucks working with providers that don't give you that time of day. So I love having that great relationship with my doctors. And I love educating other nurses, but I don't like when nurses are very condescending and you're like, right in what you're saying. Like, there's just no need for that. I like to be in an environment where I'm like, you know what? If I don't know something, please elaborate. Please teach me. Because if I'm doing something wrong, I would like to know. But the way you speak to people, if you're gonna be here and be like shaking your head and pointing at things and looking at me up and down, like, why? There's just no need for it, especially when you're wrong. Like, just culture, you guys, just culture. But anyway, thank you guys so much for watching my video. See you on the next one. Bye.